Good afternoon, everyone, and welcome to the fourth trimester and beyond, the case for broad investments in maternal and child health. My name is Marissa Casillas-Barnes, and I'm a member of the New York Fed's Community Development Team. This program is in partnership with NYU Rory Meyers College of Nursing, the Low Income Investment Fund, the New York City Department of Health and Mental Hygiene, and the Robert Wood Johnson Foundation. Please note that all remarks are on the record and that this event is being recorded, and the recording will be live on the New York Fed's website for public viewing. There will be no Q&A. Without further ado, I would like to introduce our first two speakers who will provide welcoming remarks. Noreen Hassan, First Vice President and Chief Operating Officer here at the Federal Reserve Bank of New York, followed by Dr. Eileen Sullivan-Marks, Dean at the NYU Rory Meyers College of Nursing. First Vice President Hassan, the floor is yours. Thank you so much for joining us.
Thank you very much, Marissa. Hello, everyone, and welcome. As Marissa said, I'm Noreen Hassan, the First Vice President and COO here at the New York Fed. Before I begin, I want to thank our co-sponsors, the New York University's Rory Meyers College of Nursing, especially Audrey Linden and Mimi Niles, the New York City Department of Health and Mental Hygiene, the Low Income Investment Fund, and the Robert Wood Johnson Foundation. I should also mention that my remarks here reflect my own views and not necessarily those of the Federal Reserve Bank of New York or the Federal Reserve System, the necessary disclaimer. I'm speaking with you all today because of my role at the bank, but I'm also a mother of two, and I'm profoundly aware of the health challenges that so many mothers face in that first, second, third, fourth trimester, and frankly, all the trimesters that come afterwards when we've all stopped counting. The topic of maternal health is one that is extremely close to my heart. With my second child, I faced a life-threatening issue for my baby in the third trimester and for myself in that all-important fourth trimester stage when the attention on new mothers can wane, but the issues don't. I had the benefits of high-quality care, the ability to strongly advocate for myself and my mother, who nagged me that everything wasn't all right and please go back to the doctor even when I didn't want to. Those advantages saved the life of my child and mine as well. Without them, my outcome may have been far different. That's why I'm personally so glad that we are coming together to discuss this new and critical area of focus for our community development team, maternal and child health. This is important to us at the bank because a healthy economy requires healthy people, a fact that has been undeniable throughout the pandemic. When a person's poor health is both a cause and a consequence of systemic racism and a lack of access to quality care, it can lead to a host of problems, including having an effect on economic mobility. Mothers, especially Latinx and Black mothers, are so important to our economy. Unfortunately, mothers of color are disparately impacted by the flaws of our social safety nets, including access to quality health care and bias in treatment and care. Some of the numbers are staggering. Across the United States, Black women are 3 to 4 times more likely to die of childbirth-related causes than white women. Right here in New York City, Black women are 8 to 12 times more likely to die. Black infants in the city are also 3 times more likely to die than white newborns, a gap that is nearly 50% greater than the national average. Researchers say most of these deaths are preventable. This issue is devastating. One way to make sure that mothers have the care they need and that their babies are given a healthy start is by securing access to high-quality health care, both pre and postpartum. It's also vital that they have dependable childcare, community resources and support, and a safe and stable place to live and care for their families. One of the goals of the New York Fed's Community Development Team is to connect the dots between health and wealth. One way we are doing this is by bringing together healthcare professionals, community-based organizations, and capital providers to drive investments in maternal and child health. Our panelists today will do just that. They'll speak more specifically about effective solutions that address disparate maternal health outcomes innovative business models focused on mothers and their young children, and opportunities to drive investment towards these ideas. Now, I'm excited to introduce one of our partners and a renowned leader in the health field, Dr. Eileen Sullivan Marks, Dean of the New York University Rory Meyers College of Nursing and President of the American Academy of Nursing. Dr. Sullivan Marks will now provide a welcome. Thank you so much.
Thank you so much, Noreen, for that personal story that you shared with us. It's not easy to tell stories about our own vulnerability. And I think that brings us today as to why at NYU Rory Meyers College of Nursing and also the American Academy of Nursing, we feel that this particular topic of health equity gaps in mortality and morbidity for women of color and all mothers and children who are undergoing the maternal experience is so critical. When you think about it, what is more human than the experience of birth? And yet in healthcare, as I said to Representative Lauren Underwood's committee that was looking at ways that we can improve legislation to support addressing health equity gaps, is that we in healthcare have really failed in this regard. And when we recognize in healthcare that we failed, it's time to put effort into what's the root cause analysis of why we failed in these gaps of care, but also how do we make it very much a central part of our health efforts. So, for example, how do we change the ways that we view care of mothers? How do we change ways that we practice? How do we address how we teach? How do we bring more folks into the fold from the community? And then how do we advocate and make change? And we will hear from our panelists and speakers today that will be speaking to these very issues that I expect will lead to action. I want to particularly thank the Federal Reserve Community Development Program for leading in this effort. What better way to start to make differences in social determinants of health than to partner with economic advocates. And I want to particularly thank Dr. Audrey Linden, who took leadership. She is a faculty member at NYU Rory Meyers College of Nursing, and this week she has assumed the Vernice Ferguson Professorship in Health Equity. So we're very proud to take these steps to support work to eliminate gaps in care. Thank you very much.
Thank you so much, Dr. Sullivan Marks, and thank you, First Vice President Noreen Hassan. I'm pleased to introduce our first panel, which is the framing discussion. First, I'd like to introduce Dr. Monica McLemore, Associate Professor of Family Health at the University of California, San Francisco, and Dr. Antonio Villarroel, Dean at the University of Pennsylvania School of Nursing. This panel will be moderated by our close friend, Dr. Audrey Linden, Assistant Dean for Clinical Research and the Vernice D. Ferguson Professor in Health Equity at NYU Rory Meyers College of Nursing. Dr. Linden, over to you.
Thank you so much. And thank you for those wonderful remarks. I second my gratefulness for Noreen, your willingness to share your personal story. That's such an important part that we all can hear and understand the impact of these issues on our community. I also want to take just a moment to thank everyone who's participating in this event today and the team at the Fed for their incredible convening and hosting capacity. So with that, we'd like to jump into some discussion with our panelists. Both of our panelists, Dr. McLemore and Dr. Villarroel, have spoken in other venues about the social structures that impact health across the life course. And we'd like to take a few minutes to dive into that. So Dr. Villarroel, would you start us off by sharing a few thoughts about how social and structural factors are connected to maternal and child health, and how these factors reverberate over time, and particularly in terms of housing, childcare, employment, and other aspects of the social safety net.
Sure. Thanks, Audrey. And first of all, congratulations. I think all of us who know and loved Vernice know that she would be thrilled with your appointment. I'd like to also give my thanks to the New York Feds and also to the NYU Rory School of Nursing for co-sponsoring this event. And, you know, while it might seem like a strange partnership for the New York Fed Trust to partner with the School of Nursing, it makes perfect sense to me in addressing maternal mortality and morbidity as well as child health. Maybe not the usual partners, but we need a seismic shift in addressing these particular issues. And I think just thrilled to be a part of this. So while I'm not an expert in reproductive health, that is my colleague here, Dr. McLemore, I both lived experience and professional focus on addressing structural barriers, racism in health, social determinants of health, unconscious bias, building a culture of health at the National Academy of Medicine with my colleague Otto Kerr from the lens of a Latina nurse, researcher, and leader, and particularly in the area of child and adolescent health. We know, or again, the predominant theories that are coming into play is recognizing how important pregnancy is, and even before pregnancy is, for the healthy development of children. So theories of early programming model and cumulative pathways models provide support for a life course perspective for maternal and child health and development. But I'm going to start here with women, women as the center here. And I want to start with the vision that was adopted by the Lancet Commission on report that was led by Dr. Anna Langer at Harvard and Afaf Melis at the University of Pennsylvania School of Nursing. They put forth a vision of women and health, which I think is apropos for our discussion today. Their vision was that women who are healthy throughout their lives experience gender equality and are enabled, empowered, and valued in their societies, including in their roles as caregivers, are well prepared to achieve their potential and make substantial contributions to their own health and well-being, to that of their families and communities, and ultimately to sustainable development. Maternal and child health is a symptom of a much larger issue. It is reflective of the limited investment in women and health around the world and in our country that can be traced to the existence of inequitable structures that adversely affect women, and especially women of color, and in turn, their children. Here are but a few examples of these structural issues. First of all, taking a look at the workforce. Our society has failed to recognize and value women's paid and unpaid contributions. This inequity has been codified into law, was codified into law as early as 1938 with the Fair Labor Standard Act, which again, among other things, went to the protection of child labor and the established minimum wage. But in order to pass, there were some compromises that needed to be made. And so therefore, farm workers and domestic workers were excluded. And again, those are positions occupied and still occupied by people of color and women. This led to lower incomes for Black and Brown people, as well as the accumulation of wealth, and again, lower standards of living. Restrictive immigration policies are another form of structural racism, and it limits access to needed resources, healthcare, and education. And again, even the threat or the belief that ISIS is in the neighborhood, and these aggressive enforcement practices have led to lower births among immigrant women, as well as food insecurity and mental distress. Our country is one of very few developed countries that have a limited family leave, paid leave policy. We also know, brought forth in the light of the COVID pandemic, that women's contributions in healthcare, the labor force, and again, talking here about nursing, and their crucial roles in the healthcare of communities are drivers of wealth and health of nations. I'm going to move on to gender inequity. The male-female wage gap remains larger after more than 4 decades in which women outnumbered men in college. And we know that as women move into male-dominated fields offer less pay in return. And again, we've seen this in fields such as recreation, biology, computer program, that again, on the opposite, increase when the percentage of males are increased. There's the issue of gender-based violence and the lack of accountability for perpetrators. Today, there is a Senate hearing in which our treasured athletes, our gymnasts, are testifying about how sexual abuse was allowed to take place for years and ignored by the FBI, and again, put them and again, a generation at risk. There is a lack of protection for women and families. All of these conditions have led to limited economic mobility, lack of access to land, financial resources, and technology. And finally, I'll end with the politicization of women's health. I think my favorite comment by Kamala Harris during, now Vice President Kamala Harris, during the Supreme Court nomination hearing of Justice Kavanaugh was the question, do you know of any laws that the government has power to make over the male body? I think we can list many laws that have power over the female body, but again, the politicization of women's health is absolutely a structural barrier that needs to be overtaken. So these are our challenges, but I think in partnership, I do feel encouraged that we can address these particular issues.
You've given us a lot. Dr. McLemore, would you like to add anything to those comments?
Well, I would, first of all, I would like to thank the organizers of this panel, and I'm very grateful to be on with both of you. I hope you will call me Monica, and I use she and her pronouns. Dean Viorel, as someone who doesn't directly work in reproductive health, you've clearly outlined, I think, some of the important issues and aspects of the global inability for us to be able to optimize experiences for half the population. So I need for people to really, really understand that, pregnant capable people who have uteruses, people who are, half of the population do not have the same rights of citizenship, whether that's global or geographically located, that other people do. And I really think that it is beyond time for us to be able to act to ensure that not only health outcomes are improved, but also human services, and that we also connect the dots around, how these issues are all connected and all related. So I really appreciate, the beautifully expansive overview that you've provided us, despite your stated claim that you're not a reproductive health expert.
Thank you. Monica, picking up on that, maybe taking it a step further, you have spoken several times about the differences between retrofitting, reforming, and reimagining where we are now. This may particularly appeal to me as a former Californian, but I think it's a really powerful construct. And I wanted to invite you to speak with us a little bit about how that framework might help us think differently about maternal health and how it could help us make tangible differences for the folks who are most burdened by health inequity.
Well, I really appreciate that. And being a Californian, we see buildings that are retrofitted for earthquakes, right? So one day it really dawned on me that one of the reasons why we are having a difficulty in understanding how to resolve not only the Black maternal health crisis, but the maternal health crisis more broadly when we think about rural populations and when we think about the loss of obstetric providers, when we think about our workforce and how so many counties don't even have obstetrical care, right? And prior to the very sobering and depressing statistics that came out this morning, reported by Johns Hopkins, based on US Census data, that 1 in 500 people in the United States have died from COVID-19. Let me remind the people who maybe are not, healthcare experts who are on this call, that prior to this, childbirth was the #1 reason that people were admitted to hospitals in the United States. We have almost 4 million births per year. And so this idea that we don't understand the impact that birth has on healthcare and health systems is really important. So one of the reasons we can't have what I think to be our congruent discussions or conversations, because we're not all having the same conversation. Some people are retrofitters, and some people are reformers, and some people are reimaginers. And some people do all three relatively well. And for years, it took me forever to realize it's not a continuum, it's a circle. So from Merriam-Webster, because I am a technically accurate scientist, I'm going to give you brief definitions of what retrofit, reform, and reimagine are, and then I'll talk about why we're all not having the same conversation. So retrofit is to adopt to a new purpose or need. To adopt to a new purpose or need. This tells me that the existing structure is actually going to remain the same, right? That's an important point. To reform means to put or change into an improved form or condition, or to amend or improve by changing said form or removing faults. Let me say it again. To put or change into an improved form or condition, or to amend or improve the change of form or removal of faults. For me, reform means that something might actually change, that structurally it might be different, and that we're not constantly adding on new work, adding on new things, because reform means that we can take something off of a plate. Then you have reimagine, and that's to imagine again or anew, or to form a new conception of, right? So to imagine again or anew, or to form a new conception of. How does this play out in reproductive health rights and justice when we think about wanting to address maternal health, Black maternal health, or maternal health crisis? Well, some people want to be able to retrofit what we already have. So to Dean Villarreal's point, if we had paid family leave and we can increase the minimum wage and we could close the gender pay gap, those are retrofits because the essential structure that we want to leverage stays in place. It's just we improve it. But if we really wanted to reform that, wouldn't we just decide that everybody needs a basic minimum income in order to live, right? That healthcare is a right and that it shouldn't be like, provided or afforded because you're lucky enough to either have an employer-sponsored health insurance or you can actually afford healthcare, right? That a reform of that would make a basic statement that we are going to provide coverage for all citizens, like a national health service or a single payer, right? That's a reform. But a whole reimagine would be, okay, so if we're going to blow all of this up and remake it in a whole new way, which I am on the record in saying that the pandemic should have taught us that that's the route that we should have gone, because we had a natural experiment to look at paying people to stay home. We had a natural experiment for paid family leave. We had a natural experiment to really think about, how could we restructure health services provision? Then we might think about things like having baby bonds, where you can invest for people who have children or those who don't, like me, who are aunts of the year, can make investments over time as baby bonds that would allow for folks to be able to enter adulthood, knowing they had some, not only financial safety net, but social safety net. These are circles, right? These are not one-time events where you're going to retrofit one thing and reform another thing, and then it's not stepwise, it's circular. So we could all figure out where we were in the discussion, right? What domain do you sit in, or which discussion are we having now? Is this a retrofit discussion, or is this a reform discussion, or is this a reimagine discussion? And I think we might get further with both healthcare policy, as well as health services provision, as well as public health, as well as human services, as well as how we set up financial systems, as well as other social systems to be able to operationalize health equity.
Thank you. Dr. Villarreal, do you have anything you'd like to add to those comments?
Just lots of reflections about where we start and where the opportunities might be. And I think, Monica, if I may, I think the idea that COVID really did blow things up for us in many ways. And we do have an opportunity, as I say in my school, it's not back to things as usual, it's back to the future. because we did things that we never thought were possible. We did things that we didn't want to do. And so to go back to those structures that we had before doesn't make any sense. And so I think thinking about this opportunity in COVID to think about what did we do and what structures do we need to do to change, I think are important. I am in the Reimagine space, but then I get dragged back into reality and say, what is it that we can really, in this fractured time, really accomplish? So that's what I'm struggling with.
Mhm.
Well, and I also, you know, to your point about being in the Reimagine space, right? Everybody can't be in the Reimagine space because we can't abandon the people of the now, right? We need retrofits. Our students, so we're both faculty, or we're all faculty, right? Our students need us to retrofit existing structures, right? But that doesn't mean we can't reform them. And that doesn't mean that there can't be other people over here reimagining. But if we all spend too much time reimagining, then nobody's retrofitting and nobody's reforming. And I think we can build muscle in all three places to really be able to make sure that we have this consistent circle, but that we allocate our resources appropriately, right? So remote work, that cat is out the bag, right? We really should be thinking about how to optimize remote work for people for whom that really works, and how to make sure that people have the supports that they need in order to be able to do that. But we also need somebody to retrofit connection.
Mhm.
Right? Same for our postpartum patients, right? We've moved to telehealth, but that can't be the exclusive way that we engage with folks. We still need the drive-by baby showers. We still need all of those social connection pieces, right? So it's always a both and knowing where we're at on the circle is very, very helpful in learning how we can reallocate our human and money and time resources on that continuum.
And perhaps one example of that might be that in healthcare, we've been historically very individually focused. It's always about the person with the chronic condition and how we can address that, or what do they need to engage in terms of behavior change to attain health. And I'm thinking that this might be a framework for moving beyond that to think more broadly about healthcare per se. And so I'd love to hear some comments on that about how do we get to community-based solutions that support families in all aspects of their lives and thereby promote individual, family, community, population, health equity, and economic prosperity, which is
So
also a mouthful.
if I were going to use Monica's framework, I'd go in the reimagine space here as well. And I would say we absolutely have to move and realign the resources out of these safety net hospitals and safety net health centers into safety net communities, of which the hospitals and the healthcare systems are just a part of. So, I mean, I love the idea of realigning resources to be able to make that happen. So I think we absolutely need a change in our approach. I mean, childbirth, pregnancy is not a medical condition, and we should stop medicalizing it. And again, if we figure out what are the resources and support that women, children, and families need, it's going to get us out of the health system. And again, it makes us partner in a different way and allows us to think more holistically, you know, again, about using community resources. You know, I can think of a community co-op for childcare, for example. You know, I'll take care of your kids, you take care of my kids. We have this training, you can pay me to do this, I'll pay you to do that. You know, I mean, but it can be community-driven and community-driven solutions. So, I mean, I'm hoping that the New York, you know, with what you're thinking with the New York Trust is being able to, you know, do some mini experiments in communities and groups of people that can define their own solutions in figuring out how to best care for families within, you know, a defined geographic condition. So that's my reimagine.
Well, then let me take us back to retrofit. Okay. I think Vice President Hassan said this best in terms of really thinking about a more holistic approach, but each person or each entity or domain doing their own part. I'll give you a perfect example, right? And I completely agree with you, Dean Villarreal, around this
Tony, you can call me Tony.
birth. Thank you, Tony. But, you know, everybody talks about doulas and midwives, right? That we want to think through, a healthcare workforce that it looks like the people that we serve, that has cultural relevance to the people that we serve. So, I want to put an exemplar out there that, the new pilot project for the Birth Justice Fund to be able to make available, up to $1,300 grants to provide doulas for every birthing person who wants one. That is a, low-hanging fruit way to really think about how do you get birthing people something that they need, and also appreciating the fact that that is an episodic retrofit. Birth is an episode, right? Pregnancy is a trajectory. So if we can think about other more upstream ways, or when I think about projects that I'm associated with here in California, we're feeding postpartum moms, right? That's not a technologically high, solution. That's a low-tech solution. But to get them nutritious meals delivered to their home 6 weeks postpartum, to make sure that they're well nourished and that their nutritional capacity can not only be enough to support themselves, but lactation and chest feeding and breastfeeding in the postpartum period, that's a retrofit. It doesn't require any new ideas. What it requires is a reallocation of resources, though. Right? So you stay in reform and reimagine. There are some of us who are really good at retrofitting. And one thing that's so important about the framework is that we can't operate from scarcity. There is enough, right? That's the other, but our problem is, I think a lot of times when the health services provision sector really dictates things, we never want to let anything go. We always want to add on. We always want to maintain. We always want to control. But sometimes letting pieces go to be managed by people who can better manage it, especially in communities who know exactly what they need, is a win-win for everybody.
So Monica, I just have to say you'll be really, really pleased because I am in the Reimagine space, but I am very practical as well. So our Center for Global Women's Health is starting off a pilot project where we're supporting the education of community workers to be doulas, and they're going to be trained with our nursing students. So to have that type of interaction there, and then we're working with our health system to make sure that they get employed in that particular area. So I'm just so excited about that opportunity. Our students are absolutely thrilled. I mean, and this is absolutely a win-win for everyone. So yeah, we have to walk and chew gum at the same time, and we can, so.
And I think that interprofessional and intergenerational learning, including community members, is the only path forward. I think that this is where reproductive health rights and justice can lead the rest of healthcare in really sort of tying in authentic community engagement to education and training and workforce development, and we will see improved health outcomes on the back end. But in between, we will see improved experiences both for the learners as well as the people we serve. We will see perceived increases in confidence and competence, other metrics that aren't just let's end preterm birth, let's end maternal morbidity and mortality, right?
Exactly.
There are reform midpoints that we can be looking at as markers of improvement.
And I would just would be remiss not to mention another retrofit and reform, which would be for us to really think hard about how, building on what Dr. Viruel was speaking about the students, is to building up. We have a huge nursing workforce that really is not spoken about in all of the healthcare and community-based solutions. And it would be so fantastic to rethink that as well. So I think we are about out of time for this panel. And I really want to thank both of you for taking the time to join us and really having a fantastic discussion.
Thanks for the invite.
Thank you for having us.
Thank you so much, Dr. Linden, Dr. Villarruel, and Dr. McLemore. That was fantastic. I'd like to introduce our second panel, the fourth trimester. On this panel, we have Lisa David, President and Chief Executive Officer at Public Health Solutions, Savannah Brown, Co-Executive Director at Black Women's Blueprint, and Valerie Barton Richardson, Chief Administrative Officer at CAMBA. And this panel is being moderated by our other partner, Dr. Mimi Niles, Assistant Professor and Faculty Fellow at NYU Rory Meyers College of Nursing. I'm going to turn it over to Dr. Mimi to moderate. Thank you.
Thank you so much, Marissa. I do want to start also by honoring the individual and collective expertise that is in this virtual space right now. I consider many of you my mentors and thought leaders in this space, and I'm so proud to be representing Meyers College of Nursing to facilitate this conversation. So in maternity care, as Dr. Linden mentioned in the previous panel, we tend to really become hypervigilant at the birth event, as Dr. Linden called it. And we become very observant and we invest a lot of our resources at that moment of birth, when so much more of health happens outside of that room. And I consider you all experts in the community and people who are very proximate to families and the community. And I'm hoping that we can spend our time together sharing with our audience what that looks like, what the work looks like, what the aspirations are, and what really needs to happen in terms of dedicated and thoughtful investment in the resources to building the abundance in our community. So I'm going to start by asking, can you help our audience members make broader connections between the health and well-being of a family unit to the strength of the community? What does that really look like? And how do you experience that in the services that you offer? So why don't we start with Savannah?
Good afternoon. Thank you so much, Mimi and Lisa and Valerie, just for the opportunity to be in conversation with you, and grateful to be diving in a way that feels authentic today, this afternoon, for all of us. And when I think about centering the family inside of the community and the strength and well-being of the community, I actually just see them as intrinsically and integral, right? And I think when I think about the communities that I serve and that I work with and that I represent, most of the time, families are not nuclear, right? Most of the time, families are communities, and there's this blending and there's this hybridity of where people come from and how they exist, survive, and thrive, right? And so when I think about the strength of the overall community, I think about relationships, right? I think about the ways in which people or persons within that family or community may be engaging or interacting with violence or lack of safety. I think about culture. I think about culture as health, and I think about the broader connection and relationship between the ways that food and music and creativity and expressiveness are a part of the health and strength of a community. And then I also just think about what's available. What is that community already sourcing for themselves? Often, and I know we'll get to this shortly, communities are filling the gaps where unfortunately the system is failing them, right? So there are these assets or these strengths that community are constantly lifting up or raising up in order to support themselves or their families or their communities. And that could look like basic tenant organizing, right? Like in a housing community, or it could look like food justice and mutual aid or sharing from the garden, right? That the community is building collectively or individually, or a community baby shower, right? There are many ways in which I believe that communities are filling the gaps and naming for themselves where strength and hope and resistance gets to exist. And I think about also when we think about the strength of community and the individual and the family, where we're at just in terms of our social conditions, right? And racism, sexism, the isms as they've also been superimposed into the COVID pandemic, right? So primarily many community members are living in isolation, they're sheltering in place, away from their homes, away from each other, away from the necessity and the survival of community. And so it breaks my heart even to think about the ways that birthing people, especially, have been in such deep isolation over the course of the pandemic, and what would strengthen or weave or suture their capacity to thrive and survive. Much of that has either been broken or has been tampered with as a result of this broader like kind of condition that we're situated in and the circumstances that we're situated in. And so I think about women of color, I think about trans communities, I think about birthing communities who we say are at the margins, but are really at the center of their own communities, and also perpetuating and creating strength and survival in their communities.
Thanks, Savannah. Valerie, would you like to share?
embedded in, what are the strengths that are happening in the communities and what are the resources that are happening right now. And just to put in a little bit of context, Canva provides holistic services to about 65,000 New Yorkers citywide. And we're really about the family and the focus and what's needed. So that's both, do you need job training? Do you need education after school? What do we provide in infant and maternal health care? And how do we make those connections and make families stronger? We know what's needed to make families stronger. It's not a mystery. It is, what are the strong supports that are available in many different communities throughout the city? So does mom have somebody who she can talk to, share with, someone who's going to help her develop her voice? Are we going to be able to provide the concrete services that we do to moms, both prenatally and post-birth, that says, you're leaving with this child, do you need help and support in breastfeeding? Do you need help and support in safe sleep education? Do you need help and support in connecting with other resources in the community? And how do we strengthen mom's voice? How do we take a strength-based approach and make sure that moms and families have what they need in the long term, right? Across the ages. So not just with a newborn, but when that child is 3, 4, and 5, and making sure that children are well immunized, that children are connecting to quality early care.
And Lisa, do you want to offer any insight?
Sure. I think, it's kind of the way I think about it to relate to it is a family is like a subsegment of the community, right? It's a piece of the community. And a healthy family is a healthy member and makes the community healthier. And if you just think about a family, there's one person in a family that is really struggling, say they have a medical or mental health issue or lost their job, whatever, it has an impact on the whole, right? And if the family isn't functional, I mean, if there's all kinds of dynamic tension within it, it has an impact on the whole. And, we see this in communities. We've seen this in COVID, where communities who already were under-resourced were disproportionately hit in terms of job losses, in terms of closures, in terms of evictions. That eats at the community. So building strong families and healthy families is essential to having healthy communities. What's interesting to me is the time of creating a family, having children, is a time where needs change dramatically, but also personal commitment to behavior change is much more open. It's a huge opportunity where you can build strength in a family and set a family up for success. Despite organizations like ours working very hard at it, as a system, we don't do well at this time. I was on the Mortality and Morbidity Review Committee in New York City for 2 years. Over half the deaths were preventable. And a lot of them have to do with the social situations of the pregnant woman. It has to do with the functionality of the housing they're in, the safety of the housing they're in. Do they even have a refrigerator so that they can have healthy foods? It has to do with the fact that there is huge distrust of the healthcare system. If that wasn't abundantly clear from COVID with vaccine hesitancy, I mean, that's not new. That exists for a reason in the way people are treated when they interact, especially women of color, when they interact with the healthcare system. And so we have this fundamental issue of not having healthy pregnancies. We have a lot of issues of the impact that has going into delivery, having bad outcomes. And then you have the first 3 years of life of this child, which set a child up for success. All the brain development, for the most part, 85% is happening in the first 3 years. And so if we want to have a big impact on families and communities, this is the primary place to focus. I mean, we're going to affect a new generation if we can do this better. We're going to lift a new generation if we can do this better. And it, going back to earlier, there's lots of retrofit opportunities. There's lots of reform opportunities. I guess you could move to France and that would be reimagining. But it's just an incredible place to focus and invest because of the impact that it can have.
Yes, thank you so much. I mean, I want to build off the first panel too, in terms of, a lot of resource and research is sort of channeled into to uncovering what the disparities are and what the scarcities are. And in my work as a midwife, I find that the scarcities really exist in the structures that surround people, that's what has really been under-resourced and under-invested in. So I'm thinking about housing, safe, stable housing, and schools, and public clinics, and even green spaces. I would like you all to talk to us about the ways in which you've seen the communities you serve struggle with the scarcity of the structures that don't efficiently and effectively wrap around people.
I mean, I can say, oh, go ahead, Valerie.
Sorry, I think that if you think about mom leaving the hospital, where is she going? Is she going to an apartment that she can afford? Is it overcrowded? Is she afraid of being evicted? We know that over 50% of New Yorkers are rent burdened, and even with the pandemic relief dollars that are pushed in, folks still need to apply, and that's a stressful process. Is she going home to a homeless shelter? We run a number of homeless shelters. We provide great service, but it's still stressful, right? I need a permanent place to be with my child. And so, just around the issue of housing that we think is so central, is she going home to a building that's well maintained and pest free? Is she worried about asthma? Is she worried about other kind of health issues? Is she food insecure? Does she have enough food for her family? Does she have a responsible network around her of other adults who are going to help her in care for this child? We all know you can't do it alone. Is she going to be able to have high quality infant and toddler care if she's looking to go back to work? Is that available in her neighborhood? And does she have access to it?
And just building on that too, I want to be sure that, as we all come from various sectors and we're thinking about this, that often the burden gets placed on the birthing person, right, around what their social circumstances are and their social conditions are, right? And so when we think about de-siloing our work, right, addressing maternal and infant health means addressing housing justice, right? It means addressing food justice. It means addressing clean water, clean air. Climate justice is reproductive justice. And so I just want to draw the connection. And for some folks, that might feel like a leap of like, why would we be talking about that thing? But there is a notion and a concept around weathering and toxic stress and the ways that racism and structural issues, those systemic issues, they seep into and again become superimposed onto issues of infant and maternal health, infant and maternal mental health, right, in the postpartum phase and beyond, and can actually inform the lifespan of a birthing individual, can inform the lifespan of an infant or a newborn. And so I just charge us to be thinking about the interconnectedness of these issues and also de-burdening the birthing person from, if only you had food and housing and you were out of that violent relationship and those things, you would have a different birth outcome. There's something that's deeply systemic and also inter and multi-generational that has to be undone, right? That actually has to be addressed systemically and has to be addressed even socially in the ways that we think about what birthing people need. And again, I also always centralize, again, when you talk about like where is it not just scarce, but where is it rich within birthing people's lives? Again, with culture, right? And often we rob people of that when they enter into systems or they enter into medical facilities, rob them of their wisdom, their language, their spirituality, their rituals, right? Their access to the foods that people in their communities and in their cultures eat in order to sustain themselves and be well in the postpartum phase. And so I believe that there is also a way in which there's a responsibility that gets to be placed, I think, even at an institutional level, of honoring from a place of cultural humility and relevance what the birthing person needs in order to do exactly what they need to do, which is to fill the gaps where the system is not able to to honor that, right? And so know and witness the fact that people are already using protective factors against these risks, against risks of preeclampsia, against risks of pulmonary embolism, against risks of postpartum and postnatal depression and psychoses. People actually have the tools in their hands, and all we have to do is honor, bear witness, and hopefully shift policy in order to honor and sustain those practices that community is already engaging in.
But the other thing I'd like to add to that, this, because it's so core and central, is that our approach to human services in general burdens the individual. It's like our system is incredibly fragmented. There are probably 20,000 community-based organizations in New York City, and they all heads down are really trying to do the best for the families and individuals that they're working with. And we're even restricted by funders to share information, and everyone uses their own IT systems. I run 11 IT systems for different funded programs. It's insane. And there's sort of this sense of the best we can do is give a referral for something. So we are burdening pregnant women and new moms sort of with the isolation of they have to try and figure this out, depending on what their network's like that they could offer them for suggestions. And then when we go to do it, it's on them to figure it out. And none of this is easy. The eligibility requirements, the paperwork, it's a bureaucratic nightmare to actually get the services. So part of what we need to do, and billions of dollars have been put into the hospital system to try and get them to integrate and to connect to the next steps outside of a hospital, is to get some kind of infrastructure that coordinates that on behalf of moms and individuals. So that, I guarantee you, if you're sent to go for a home visiting program or some food access program and you're not eligible after you figure out how to get there in the hours that they're open and fill out all the forms, if you don't get it, you're done. It's like, you can't take another day off, you can't drag your kids in there, whatever. We do not make it easy. And maybe this is a combination of reform and retrofit. We need an infrastructure that manages this, so that you could do a comprehensive assessment. We know it can, but we know in all these organizations, people don't have one need; they have several needs, and maybe they're hierarchical. But we can get more than one service to people, and we can take the burden off of them to figure out how to do that. So infrastructure on those human services, social services, I think is an investment that should be made. I will say, it's my experience, and I think we've heard this through this discussion today, the single most important thing that throws people off is housing. If you don't have stable housing, you can't address your other issues very well. And if you've been plowing along and then you lose your housing and you're evicted, it's all gone, because that's the only thing you can focus on. So combinations of sort of more family-oriented shelters, which generally do a good job, but affordable. We have to get really affordable, not quote unquote affordable, truly affordable housing for folks in New York. It doesn't exist, it's going away. And fundamentally, if we can't solve that problem, it's hard to make sort of consistent and sustainable change in a lot of the other areas. And then what I just want to say about women and families is we have programs we know work well. We know doulas are really helpful as the advocate for a patient in an incredibly stressful situation during birth. And they usually come in before and they stay a little bit after. But home visiting programs, which can go from 3 to 6 years for a pregnant woman to the first 3 to 5 years of the child's life, is like a life coach relationship, a coordinator for the services they need. And again, has huge impact. We know there's randomized controlled trials out the wazoo, but only 10% of women who are eligible for this kind of support in New York City are getting it. And so we know there are empowering programs and skill building programs that wind up with families that have moms who've met their educational goals and gotten a job that they can sustain their family with, and making sure everybody gets access to healthcare, maternal primary care, pediatric primary care. Kids do better in school, they wind up making more money, there's less mental health problems, there's less incarceration. I mean, there are proven programs out there that really are empowering and skill building in families, and we just don't make them widely available. And so
Thank you.
some of it is just allocating the resources to do that.
Yeah, thank you so much, Lisa, for that insight. I just want to spend the last 3 minutes of the time that we have together. If you can leave us with your aspirations, and really, again, using Savannah's word, the abundance that exists in communities, and really wanting to uplift and amplify that. So with the right combination of community and civic governance and local and federal policy and private investment and public investment, what would you say would be, I think housing comes forward as a predominant theme, but where is the abundance in the community, and what would a community need to thrive, if you could name something quickly in these last few minutes?
I mean, dare I say land, right? Make land accessible to people to live and thrive and birth and create families that are healthy and sustainable, not just for themselves, but also for the planet. To me, there's no reason that Native and Black people should be at the top of the list in this country of folks most likely to die a preventable death in pregnancy and childbirth. There's no reason, right? Given the intrinsic nature of their building and being of first peoples on this land, right? And so I deeply believe there's a relationship between reproductive justice and land sovereignty and land justice and the sustainability of our communities, right? And that the tide will be turned, right? If we can only see people with healthy food and stability and a place for their children to grow and be free and happy and healthy. So dare I say land as the first and primary investment, and also free and liberate land, right? Land is not, does not belong to any of us. And so I think there's also just a construct that needs to be deconstructed around land and land ownership and legacy.
I just a couple of thoughts. Housing is healthcare, right? Whether it is preserving existing housing, the government is moving in the right direction in terms of increased rental subsidies that really actually pay for the cost of housing, keeping people in the housing that they have, rehabbing existing housing. We need new, deeply affordable units, but we're not going to build our way out of this. We need to be able to preserve. I would also want to look at issues of a quality system of childcare, infant and toddler. I think that what the pandemic showed us was that system really didn't work. It didn't work for the workers. It didn't work for families. And how do we really have a truly high quality system of childcare in New York? And I would say the third piece is lifting up families, right? Families' voice and choice and opportunity. And I always talk about the New York City Department of Health community health profiles. I think they do a great job of illustrating what are the resources that all families need to thrive, and how are they disproportionately allocated throughout the city based on some legacy of structural racism.
And I guess I would say we need to invest in all ways to create more equity in our communities, and that should be sort of community driven. So my aspiration is that we could eliminate most of the barriers to that. The way that, our policies around housing, our funding around public housing, our electoral system in terms of gerrymandering, that it's not going to happen unless we really make a commitment and really believe that we can create equitable communities, because the forces working against that are so strong. And fundamentally, it takes a fundamental, this is the aspirational part of it. I feel sometimes like in our work, we're addressing the symptoms of the structural barriers that are here, and we're not changing any of them. We're just trying our hardest to make it a little better for people. But fundamentally, and if not now, after what we've lived through with COVID, where it is 100% visible to everybody that the inequities that happen from COVID are there because of the inequities that have existed forever in this country, and have been legislated and regulated and put into policy. I just feel like if we don't have the ability, we have to figure out how we can address some of these things, maybe one at a time. But otherwise, we're treating symptoms. And that's not to say there's no benefit to that, and we should. And we should put more resource and coordination and infrastructure behind it. But, the elephant in the room is the system's against us.
Yes, well, thank you so much. I mean, it definitely does, offering the framework that Dr. McLemore offers us, and where are we going to enter into that circle? And we all bring different strengths. And I thank you all so much for the work that you're doing in your communities. I think we all applaud you. We all admire you. And it's time to center communities and provide deep, sustainable investments in those communities and the work that's already happening in those communities. So thank you so much.
Thank you so
Nice
much
to
to our
talk to
panelists.
everyone.
Thank you.
Thank you so much for your perspectives, and thank you for moderating and continuing to partner with us on this, Dr. Niles. Up next is our Upstream Financing Solutions panel. On this panel, we have Rachel Bluestein, Senior Vice President of National Programs at the Low Income Investment Fund, Monique Shaw, Program Officer at the Robert Wood Johnson Foundation, and Dr. Daniel Stevens, Deputy Commission of Family and Child Health in the New York City Department of Health and Mental Hygiene. And this panel is moderated by my colleague, Otho Kerr, who is the Director of Strategic Partnerships and Impact Investing at the New York Fed. Otho, over to you.
Thank you, Marissa, and good afternoon, everyone. As Marissa said, I'm Otho Kerr. I'm Director of Strategic Partnerships and Community Impact Investing at the New York Fed. One of my responsibilities is to bring traditional capital, impact investment, philanthropic, and public capital to the table to find ways to invest in solutions that'll help make our economy work for all segments of society. And in the last hour, we've identified some of the critical issues and problems associated with maternal health. And some solutions, both explicit and implicit, have been lifted up as well. But solutions need to be paid for. Public funding isn't necessarily enough, and traditional capital providers aren't always racing in because they're not necessarily going to find the return on their investment that would make it worth their while. How do we fund retrofitting, reforming, and reimagining as lifted up by Professor McLemore? At the Fed, we're looking to identify new and interesting ways that government, philanthropy, and more traditional capital providers can work together to fund maternal health initiatives, to create essentially a subsidized market for maternal health. So with our final panel, we want to explore what's been done or should be done to fund some of these solutions. Of course, we could spend days on this, but we only have 25 minutes. So to help us explore this and identify a few of the answers, are our friends, Monique Shaw from RWJF, Robert Wood Johnson Foundation, Dr. Daniel Stevens, who I'm going to refer to as Dr. Dan, Deputy Commissioner for the New York City Department of Health and Mental Hygiene, and Rachel Bluestein, Senior Vice President of National Programs with LIF, also known as the Low Income Investment Fund. Collectively, they bring a wealth of experience focused on investing in lives prior to conception, as well as the first years after birth. So let's get on with this panel. And I'm going to start with you, Monique. I'd like to explore the wonderful work that you're doing through RWJF's Birth Justice Initiative. But we understand you're a doula, which gives you an added important perspective. And a reference to doulas was made earlier, and investments in training community health workers to be doulas. For those of us who may not understand the role of doulas, would you mind first explaining the difference between a doula and a midwife? And then tell us about the financial investments that RWJF is making to support BIPOC families through its birth justice programs and grants.
Yes, absolutely. And first, thank you so much to the Federal Bank of New York for co-sponsoring this important event. I'm grateful to be in the company of such esteemed panelists, and I thank you as well, Otho, for the question. So a doula is a trained companion who provides non-medical physical and emotional support to individuals throughout their reproductive life course and experiences. And so doulas support families, caregivers, and also communities by providing resources to help people make informed decisions about their health and healthcare. And these resources and supports are vast in nature and can range everywhere from education about the labor and delivery process to aid informed decision making, to offering comfort and relaxation techniques during labor, to advocating for the birthing person within the healthcare system or healthcare setting, to helping families transition into parenthood, and to also helping families navigate systems to gain access to social services and supports. And midwives, on the other hand, are medically trained healthcare professionals who provide evidence-based maternity care through the application of a model of care that fundamentally views pregnancy and birth as normal life events. Midwives provide whole person care to women during pregnancy, labor, and throughout the postpartum period. And they also conduct births in multiple settings. And so in my dual role as a doula, say that fast 3 times, and a program officer, I'm grateful for the opportunity to work on programming at the Robert Wood Johnson Foundation that seeks to better understand how building and supporting community power, which we define as the ability of the people most impacted by inequity to create change through a shared agenda, and how that plays a very critical role in advancing birth equity and justice. And so the birth justice movement centers the perspectives and decision-making power of BIPOC birthing people to shift mindsets, systems, and conditions that affect the health and well-being of birthing people across the pregnancy spectrum, their children, and also their families. And so consequently, we've committed to investing significant dollars to support birth justice organizations that are building community power and using strategies that advance network and coalition building, that amplify and spread the narratives and solutions that are driven by birthing people of color, and that also are promoting policies and practices that address the impact of implicit bias and structural racism on maternal and infant health outcomes.
And Monique, in the work that you all do, as this session is about making those investments that are necessary to bring about, lift up the solutions that have been talked about today, can you help us understand how impact investors and traditional capital providers might work with you all in the furtherance of the work that you do, being that you come from this from a philanthropic perspective?
Yeah, so I think that's such a great and important question. And, you know, as we've heard from our panelists earlier today, you know, the maternal mortality crisis in this country and the disproportionate outcomes experienced by birthing people of color is an issue that impacts us all. Maternal morbidity and mortality has implications far beyond death in and of itself, but also has widespread impact on families and communities and their ability to thrive. And so in order for us to efficiently achieve the large-scale interventions in reducing maternal mortality and morbidity, and to improve maternal health, it's critical for us to involve multiple stakeholders and investors and partners. And so this means collectively understanding, getting on the same page and same footing around the complex challenges that BIPOC birthing people are experiencing throughout their reproductive journeys. It also includes us working together to elevate and scale solutions that are often best developed by those with lived experiences, and financially supporting and investing in BIPOC-led organizations that are both on the front lines, addressing the immediate needs of their communities, while also advocating for policy and systems reforms that center equity and access and in care, and that also promote the economic mobility for families to be able to fully participate in their communities. So to be transparent, as a philanthropic partner, we're relatively new to the birth equity space. We still have a lot to learn from our partner organizations about what it takes to build the capacity of organizations working to advance birth equity, and also what it takes to strengthen the broader birth equity ecosystem as a whole. But a couple of things that we're continuing to hear from the field are, one, that there are glaring racial inequities in both funding and capital investment that remains a persistent barrier to Black, Indigenous, and other people of color in developing, opening, and sustaining businesses that are seeking to advance community-based solutions and community-based models of care that have been evidenced in improving maternal health outcomes. There are also few investments in supporting BIPOC maternal health leaders and innovators and entrepreneurs to build skills and investment model and strategy development in an effort to increase their visibility and access to diverse funding sources to ensure their vitality, sustainability, and growth. And so we know that the scale and sustainability of targeted innovations to improve maternal health are only going to be achievable if we work together through government, private sector, and philanthropic partnerships. And so we each have a critical stake and a critical role, and there are many opportunities that can be leveraged across stakeholders and partners. As an example, philanthropic investment and loan guarantees can lower perceived risk and encourage investors to come to the table. Our ability to take on more risk in philanthropy and our ability to exercise our convening power, leveraging our strong relationships across stakeholder groups, really positions us well to be a catalytic investor. Additionally, we have the ability to gather and disseminate research and tools while amplifying the voices of leaders to help shift the national conversation in a way that opens more doors for diverse investments. And as that catalytic investor, we can also usher resources to organizations that are working to ensure that the conditions of optimal births for all people, while addressing racial and social inequities, in a sustained effort. And so ultimately, by working together in this partnership, we can identify our shared values, we can bridge our collective resources and voice, and we ultimately have the opportunity to change these community conditions such that they promote a fair and just opportunity for health and well-being for all.
Thanks, Monique. And I just want to thank RWJF for being such a critical player, bringing philanthropic capitals. It can de-risk investment opportunities for traditional capital providers who may not want to take on the risk that RWJF takes on. I want to move on. Thanks, Monique, to Dr. Dan. Dr. Dan, your department is focused on the full health and wellness of the New York community, beginning with maternal and reproductive health to school health and beyond. You've shared with me that you've witnessed a growing gulf between maternal health outcomes for our Black and Brown communities versus our white communities. What specific upstream capital investments would you make today, assuming you had all of the resources in the world, but what investments would you make that would close the maternal health and wellness gap? And as you comment, we'd be especially interested in understanding where private capital can play a role in support of public funding and philanthropy.
Absolutely. So thank you for the question, Otto. It's really a privilege to be here. I echo my colleagues' sentiments about how privileged it is to feel a part of this gathering and this community thought leaders. It's an important question. You know, I am a pediatrician, and so I say this fully. Healthcare isn't the #1 need, right? I think if I had to think truly about upstream investments, and this has been commented in our wonderful panels previously, I'd have to start with home. So many services, whether your insurance is renewed, whether you're enrolled in SNAP or WIC benefits, you have to have an address. And so people who have unstable housing, it's really hard to build a stable life. So I would start with the upstream investment being in stable and safe and affordable housing. With that housing in place, I would say then it's about meeting needs in that housing. We often talk about supportive housing, and so if you have somewhere to be, you know, can you come and actually deliver services and meet needs in that space? And I'll talk a little bit about that as well. But then the other thing we need to do is remove the barriers. And my colleague Lisa David mentioned this in the previous panel. Removing the barriers to meeting those needs. If asking for help, right, ends up with you being punished, then we disincentivize, right, even offering the help, however skilled or however great those services are. So in those 3 buckets, I would first off say safe and stable housing, supportive housing, and reducing those barriers. I think private capital has a distinct role in each of those areas. First of all, in housing, to the great framing we had earlier around retrofitting and reform and reimagining. This is retrofitting. We have housing units. We just haven't built affordable ones and accessible ones for New York. In terms of this applies more broadly, but investments in actual affordable housing, the services, and again, work for government, there may be community-based and faith-based organizations that are better at delivering those services. So making those investments in the best services that meet the needs of the folks that we're actually intending to reach. And then that last piece, reducing the barriers, that is something that from a policy standpoint, we need to write better policies, we need to advocate for better policies, but really making sure that private capital is innovating, pushing forward into those, into those initiatives, into those spaces where we say, by admitting that you're food insecure, that doesn't mean that we want to call child services. Like we oftentimes want to offer support, but we build in barriers to even accessing and disincentivizing access to that support. So those would be my broad buckets.
That's really helpful. Thank you for that framing. I'm going to jump to Rachel in a second with regard to housing. So I want to move off of that for a moment because we will get back to it. But can you think of some examples, Dr. Dan, where the city, community-based organizations, impact investors, and traditional investors have worked closely together to fund some of the solutions that have been lifted up today, again, outside of housing? Can you think of some examples that are worth sharing that might inspire some of the investors out there?
Absolutely, absolutely. I can think of 3 offhand, and I'm sure there are more. But our maternal health quality improvement network. It's a program we built working with 14 hospitals in the city on just their infrastructure and how to improve outcomes. And so we always talk about more upstream investments. I don't think we need to invest in better ventilators because by the time people are in the ICU, that's too late. But that is an initiative to work with hospitals on implicit bias training and quality improvement and things like that. That was funded through a combination of city council funding, which was a result of years of advocacy and partnerships with community members. We have several doula programs funded through city tax levy dollars, city dollars. And an example of a private partnership, a public-private partnership, is Work for Mothers partnered with the Department of Health for a 3-year grant to implement strategies to improve quality of maternal care, both at hospitals, in research and data, which is growing. One of the things we've seen in this pandemic is, data equity becoming an issue. We didn't necessarily know which neighborhoods were going to be hit worse because we didn't have enough testing, but we could see where people were still going to work. So data becomes even more central to understanding what's happening. And so this also is support of data and research and mobilization of communities around mental health. and maternal. So I think that that's a great example of a public-private partnership, which then can be amplified by city tax levy dollars. And then you have entities like the city council who are very supportive of initiatives. And so trying to bring all three to bear with also support of other partners, Robert Wood Johnson, and those would be examples.
We could talk about this all day for sure, but I'm going to move on to Rachel because I do want to explore that period after birth. And LIF is less focused on maternal health explicitly and more focused on affordable housing for families and early care and education, all of which supports families and maternal health, as our prior panelists and as Dr. Dan offered up earlier and as Monique offered up. But first, tell us a little bit about LIF, Rachel, and then share with us some of the investment that LIF has made to make a difference in this space.
Sure. Thank you, Otho, and thank you to the New York Federal Reserve and to my fellow participants for including us in this discussion of this critical public health topic. The Low Income Investment Fund, or LIF, is a nonprofit community development financial institution. So we invest in assets that are related to the social determinants of health, affordable housing, early care and education, K-12 schools, federally qualified health clinics, and various community facilities. Related to the fourth trimester maternal child health, I appreciated Dr. Dan and some of our other panelists mentioning housing as a platform, as well as housing as healthcare. Those are things that LIF believes very strongly in. What we are very focused on in terms of our strategic plan is both housing and early care and education. We work very closely with childcare providers across the country, both in centers and in home-based family childcare settings, investing to increase the supply of affordable, high-quality early care and education, which we believe is a critical element of a healthy community, supports children's and families. We talk about early care and education as having a triple halo effect with strong positive impacts for children. As Lisa David said, it promotes children's brain development at the most critical time, support for parents, often mothers, allowing them to pursue work or education and to be secure in knowing their children are in a safe, stable, enriched setting, and the economy. The providers we work with are Black and Latina women entrepreneurs. It provides employment not just for them, but for others in their community, and it contributes to the community's economies. There's a ton of scientific studies showing the value and the positive impact of high quality, culturally relevant early care and education programs. We know it changes children's lives. We know it changes parents' lives. We've quantified the social investment return as high as 12%, as well as showing that every dollar invested in an additional results in an additional $15 in parents' earnings. So it's also good for employers. It reduces absenteeism. So we know that this is an incredibly powerful intervention, and yet it's incredibly underinvested, which is a shameful legacy of dismissing women's work and reliance on women of color for domestic work and enslaved people. It's really, as sort of underappreciated as we often say public education is, early care and education is even less appreciated and less paid, frankly. As any parent or caregiver who knows who has tried to find it, it's expensive, there isn't enough of it, there are supply shortages in every state, and especially infant and toddler care, which we say is a critical time and a very stressful time for parents. It's also a huge racial equity issue because Black and Latino families are much more likely to live in childcare deserts. So for all these reasons, LIF feels that investing in early care and education is really critical for healthy families and communities. We offer loans, grants, and a lot of capacity building and technical assistance to providers to open, to expand. We support facilities development, quality improvements, business operations, financial sustainability, and we work very, very closely with the providers to understand their needs and their priorities in their communities. We do sort of standalone investments. So an example would be working with a center to help acquire its facilities so it doesn't get priced out of a gentrifying neighborhood and those families lose care. And we also have a very holistic sort of multi-sector approach, has been mentioned before, where we work with local partners and community leaders to determine priorities in their communities and often coordinate the development of housing with early care and education and other community assets, so that we're investing in a holistic way and trying to hit all the social determinants of health in a community to really improve the quality of life in that community. Those types of investments are often blending public sector funding as well as impact investors and philanthropy, which we really need to reduce costs, to absorb risk, to offer credit enhancement, as has been mentioned. Thank you, Robert Wood Johnson Foundation. And we've also done some innovative work with New Markets Tax Credit funding. We have a pilot right now that we're looking at asset building and wealth building for women of color who run home-based childcare businesses. We're working with housing developers and planners to try to make sure that people include early care and education in their planning, in their approaches to healthy communities, because it often is kind of the thing that gets left out, or it's the last thing on people's mind. So we have a lot of examples where, all of those elements are really required to bring together, to leverage dollars to invest into healthy communities. And the last thing I would just say is that we're in a critical moment right at this exact moment, because the pandemic really did highlight the importance of early care and education. People have said there was a childcare crisis that led to an employment crisis. I think it opened a lot of people's eyes. There was a huge racial equity gap. It was really scary for the economy, and people finally understand how important it is. And there is some increased attention, I think, at the federal, state, and local levels, which we're very excited about. There's money in the infrastructure bill that is going through right now. That's a new level of funding for early care and education if it succeeds. So that's all very exciting. We're also seeing state and local governments being very innovative about using developer impact fees, oil and gas revenues, tobacco taxes, other kinds of things to find ways to fund early care and education, which, we're working with those partners to try to invest that into communities. Ultimately, we hope that early care and education could be seen as a public good, the same way that public education is, and it would be funded appropriately in that way. So that's kind of a societal mind shift that we hope that our society will get to at some point. The reimagining, that's our reimagining piece.
I love that. Thank you, Rachel, and thank you for that incredibly comprehensive answer, which answered a bunch of my follow-up questions implicitly. But I'm going to wrap this up by, again, we don't have enough time to dig as deep as we'd like, but what I'd love to do is just ask you each if there is a policy or an investment idea that could be transformative and you'd regret not actually sharing it with us on this conference call today, what would that be? Just leave us with a wonderful idea that will inspire us before we wind down this panel. I'll start with you, Monique.
There's been so many great things that have been offered up already, and it's really, really difficult to just select one thing. But what I'd hope to leave with folks, and this is hopefully building on Savannah's comments earlier in the session, and that's really the challenges that we face in terms of maternal health and maternal health outcomes. They really sit squarely at the intersections of people's lives, their environments, and the systems they engage and come in contact with when they're accessing services and supports. And so birth equity lies at the intersection of gender and racial equity. Birth equity is an economic justice issue. It is an environmental justice issue. And so just as the challenges that are facing birthing people of color in this country sit at these intersections, so do the solutions. And the need for diversity and investment strategies and approaches is ever so clear. And so any policy or investment approach or model that is bold, revolutionary, and race forward to disrupt the status quo while intentionally centering these intersectionalities is key to the reimagining piece that I love so much to think about. and to reimagining an agenda that truly centers women, families, and children.
Thanks, Monique. And Dr. Dan and Rachel, I'm going to be incredibly rude and just ask you if you can, in 1 or 2 sentences, share your idea. Dr. Dan.
Sure. I think if I could make my plug for stable housing, once folks have housing, I think this was alluded to before, an infrastructure to deliver quality home visiting to birthing and expectant families, because those have been proven to have outcomes after children are born 20 years down the line in terms of education, achievement, incarceration, things. That's just one brief idea.
That's terrific. And Rachel, what do you think?
I would echo that. I would say listen to families and communities and listen to what they're saying they need. And when we do that, what we hear is housing and childcare. So, I would say we have to think about those as the critical elements of a healthy community, and they should be coordinated as part of our planning and financing efforts. And again, we think all of these things should be considered a public good and that they should be comprehensively funded and supported in that way.
Monique, Dr. Dan, Rachel, you're wonderful. Thank you for your time. We'll dig a little deeper at a later date, but thank you so much for your time and insights today, and I'll pass it back to you, Marissa.
Thank
Thank you so much. Thanks to all 3 of you. I'm now going to turn it over quickly to my colleague, David Erickson, Senior Vice President and Head of Outreach and Education at the New York Fed, to close out our program. David, the mic is yours.
Thank you, Marissa, and thanks everybody for joining us today. My gosh, I wish we had more time. There were so many great ideas. One way we're going to try, we took very good notes. We're going to be putting together a white paper. We'll be going back to many of you to expand on some of the ideas you shared so far, and some of you who weren't on the panels. We want to get as many ideas as possible into that white paper so we can ratchet up the conversation and really start reimagining the institutions that don't yet meet the people where we were trying to serve where they're at, but they can. And we are going to make those, we're going to find ways that we can work together more effectively and pay for that work so that every kid starts their lives with bright eyes and they keep them bright throughout their childhood. I just want to thank very quickly, this conference was the brainchild of Audrey and Mimi from the Rory Meyers College of Nursing. I just really appreciate both of them thinking that we were worthy partners for this effort. We couldn't have this conversation without the Robert Wood Johnson Foundation, who literally taught us how to talk about the upstream social determinants of health, and they've been a close partner with the Federal Reserve for 12 years now, bringing together community development and anti-poverty work together with public health, medical care, and health in general to have these conversations about how do you invest in the upstream determinants. The New York City Department of Health and Mental Hygiene, Dave Chachi and his team, we're practically combined at the hip at this point. They've got so many great programs that we think where there's a health and wealth overlay, and I think we're going to make a lot of progress there. And finally, the Low Income Investment Fund is literally the pioneer trying to figure out how do you create a market for investing in kids. They've been doing this for decades. They're one of the few nonprofit banks that have been doing that, and we're so grateful to their thought leadership and the work that they're doing, the practice of actually doing it, putting the dollars into kids' lives to improve those lives and improve those outcomes. Thanks to everybody. Keep an eye out for that white paper. Like I say, about 6 weeks it'll take us to write it, but thank you all for joining, and we'll see you next time. Thank you.